component from one person to another person. Blood transfusion involves two procedures: collection of blood from donor, admission of blood to the recipient. The purpose of blood transfusion is to restore the blood volume when there is loss of blood due to hemorrhage, to raise the HP or hemoglobin level in case of anemia, to treat the deficiencies of plasma protein, clotting factor, or hemophilic globulin, to provide antibodies to patients who are sick or immunocompromised, to replace hemolyzed blood with fresh blood. The general principle of blood transfusion are, first of all, the consent for the blood transfusion. Valid consent should be obtained where it is possible prior to the blood transfusion. If an emergency where it is not possible to get the consent, information on the blood transfusion should be provided retrospectively. Reason for the transfusion and a note of the consent discussion should be documented in patient's case note.
आपकी presentation show नहीं हो रही.
All patients should have their blood group and antibody status checked at first visit and at 28th week of gestation. If any blood component therapy is required, a sample for group and cross-match must be sent to blood transfusion laboratory. For healthy patient, no need to save or cross-match blood for low segment cesarean section. NICE guidelines suggest that all screening, save, and cross-match should be done locally, not from outside lab. If not possible, transport and local storage should be at temperature between 2 to 4 degrees Celsius. Patient blood sample used for cross-matching red cells should not be more than 7 days old. Cytomegalovirus seronegative red cell and platelet should be used for cytomegalovirus seronegative pregnant women. Patient with known placenta previa, 2 units of cross-matched red cells should be available in the issued fridge. These units should be replaced every week by newly cross-matched blood. अभी क्या करूं?
Sorry for interruption, sir. हमारे
ठीक है.
कामरान साहब ये प्रेजेंट नाउ के नाम से इसमें कर्सर आप करेंगे ना, प्रेजेंट नाउ के नाम से आ जाएगा.
Bird's eye view.
ओके. अब आ रहा है, आपको नजर आ रहा है? ये प्रेजेंट नाउ पे मैंने शेयर स्क्रीन कर दिया। इंटायर स्क्रीन क्या है? अच्छा जी, एक मिनट।
वो कैमरे से वॉइस है।
जी हाँ।
सर यहीं से कंटिन्यू करूं या रीस्टार्ट करूं? यहीं से कंटिन्यू करूं। General instruction on the selection of donor. Donor selection. Donor should be in good physical and mental health, and age should be between 18 to 60 years. Weight should be more than 45 kg. Donor must have normal vitals, Hemoglobin should not less than 12.5 gram per deciliter for males and 11.5 gram per deciliter for females. Must not have pregnant within last 6 months. Interval between blood donation should be 3 to 4 months. Donor must not have any infectious diseases such as hepatitis, tuberculosis, HIV, etc. Blood should not be collected empty stomach, should not be dehydrated. Following the donation, donor should be offered a sweetened drink and asked to take rest for 1 to 2 hours. Before leaving the collection center, check vitals of the donor. Donor's blood should be placed in refrigerator immediately after its withdrawal. Blood should be collected in sterile container containing anticoagulant solution. All article used must be sterile. Each donor unit must be labeled clear, readable letters, that is name, donor number, ABO grouping, RH typing, date of drawing, date of expiry, result of test of hepatitis, syphilis, etc. Recipient. When blood is transfused, it is important to keep detailed records. Checking the patient's identity and blood bag before transfusion. Type and volume of each unit transfused. Blood group and donation number. Time of transfusion, monitor the patient before, during, and after the completion of transfusion. Signature of individual during transfusion. Types of blood transfusion. Blood can be transfused as a whole blood and the component of the blood. Whole blood, 1 unit of 500 ml contain 450 ml whole blood plus 63 ml anticoagulant preservative solution, of which hemoglobin will be approximately 1.2 gram per deciliter. Hematocrit must be 35 to 40%. No functional platelet or labile coagulating factor, for example, factor 5 and factor 8, when stored in 2 to 6 degrees Celsius. Indication for transfusion of whole blood is acute blood loss and exchange transfusion. In the component of blood transfusion, red cell concentrates or packed red blood cells. 150 to 200 ml red blood cells from which most of the plasma has been removed. Hemoglobin concentration will be approximately 20 gram per 100 ml, not less than 45 gram per unit. Hematocrit 55 to 75%. They are stored in saline adenine glucose mannitol solution to increase their shelf life to 5 weeks. Indication for PEG cell volume transfusion is there is no firm criteria for red cell transfusion. The decision for its transfusion should be made on clinical and hematological grounds. Blood transfusion is almost required when hemoglobin is less than 6 gram per deciliter and is rarely required when hemoglobin is greater than 10 gram per deciliter. In extreme emergency, non-book patient and a blood group, if the blood group is not known or negative, PEG cell volume can be transfused to the patient. Platelet concentrate. Platelet concentrates are prepared from whole blood that have not been allowed to cool below 20 degrees Celsius. A single donor unit consists of 50 to 60 ml plasma that should contain more than 55 into 10 to the power 9 platelets. Platelets should ideally be grouped compatible. RH negative patient should receive RH negative platelets. If RH positive platelets are transfused to the RH negative women of childbearing potential, anti-D immunoglobulin should be administered. A dose of 250 international unit of anti-D immunoglobulins is sufficient to cover 5 therapeutic doses of platelets given within a 6-week period. This may be given subcutaneously to minimize bruising and hematomas in thrombocytopenic women. Indication for platelet transfusion are platelet count less than 50 into 10 to the power 9 per liter in acutely bleeding patient during pregnancy. For acute DIC maintenance, platelet count above 20 into 10 to the power 9 per liter even in the absence of bleeding. Other indications are chronic bone marrow failure, autoimmune thrombocytopenia, heparin-induced thrombocytopenia, thrombotic thrombocytopenic purpura, fresh frozen plasma. Fresh frozen plasma is a plasma prepared from the whole blood. It is typically frozen to minus 25 degrees Celsius within 8 hours of collection and contain normal plasma level of albumins, immunoglobulins, and factor VIII. Indication. Fresh frozen plasma at a dose of 12 to 15 ml per kg should be administered for every 6 units of red cells during major obstetrical hemorrhage. FFP transfusion should be guided by the result of clotting test, aiming to maintain the prothrombin time activated partial thromboplastin time ratio at less than 1.5. Other indications are thrombotic thrombocytopenic purpura, immediate reversal of warfarin effect, C1 esterase deficiency. The FFPs should ideally be of same group as recipient. FFPs of different ABO group is acceptable. Cryoprecipitate is the precipitate of fresh frozen plasma and is rich in factor VIII and fibrinogen. It is stored at minus 30 degrees centigrade up to 1 year. Indications are von Willebrand disease, hemophilia A, disseminated intravascular coagulation, factor VIII deficiency. Cryoprecipitate at a standard dose of 2 5-unit pools should be administered early in major obstetric hemorrhage. Subsequent cryoprecipitate transfusion should be guided by fibrinogen results, aiming to keep the fibrinogen level of more than 1.5 gram per liter. Fibrinogen level less than 2.9 gram per liter cause increased risk of postpartum hemorrhages. During pregnancy, fibrinogen level increase above normal, 3.5 to 6.5 gram per liter. Studies have indicated that during postpartum hemorrhage, a fibrinogen level of 2 gram per liter or less is abnormally low. No NTG prophylaxis is required if Rh negative women receive Rh positive cryoprecipitate. Complication of blood transfusion. Despite multiple tests, checkups, and inspection, blood transfusion can cause complications. Classification based on etiology are immune-mediated reactions, non-immune mediated reactions, infectious complications. Immune-mediated reactions. These can be hemolytic transfusion reaction, febrile non-hemolytic transfusion reaction, allergic reaction, anaphylactic reaction, post-transfusion purpura, aluminization. Hemolytic transfusion reaction. It is due to the mismatched blood transfusion and causes acute intravascular hemolysis. Can be caused because of ABO or Rh incompatibility, improper blood storage beyond 21 days, warming of blood above 40 degrees centigrade, exposure of blood to dextrose solution. Clinical feature can be fever, chill, headache, dyspnea, cyanosis, chest pain, nausea, vomiting, increased heart rate and respiratory rate, hemoglobinuria, hypotension, followed by shock, oliguria, then anguria. Management is the discontinuation of transfusion immediately when reaction is assessed, repeat blood grouping, and cross-match. Maintain IV infusion with 5% dextrose or normal saline. Large quantity of fluid should be given. Oxygen in case of dyspnea. Adrenaline, monitor vital continuously. Diuresis should be given, in which injection furosemide 20 to 40 milligram IV or injection mannitol 20% 100 ml IV. Monitor input-output, HP injury. Febrile non-hemolytic transfusion reaction occur due to incompatibility of red blood cells antigen other than ABO group. It develops days to week after transfusion. Clinical features are persistent low-grade fever with decreased hemoglobin. Prevention can be leukoreduction before storage. Allergic reaction develops anytime or within 1 hour of transfusion. It is due to sensitivity of individual to plasma protein of the transfused blood. Clinical features are itching, rashes, laryngeal edema, and bronchial spasm in severe cases. Management are antihistamine injection, corticosteroid. Extremely sensitized patient should be given cellular component wash. Anaphylactic reaction. Anaphylactic reaction develops immediately after transfusion of few ml of blood, very rare but life-threatening. It is caused idiosyncratic reaction in client with the immunoglobulin A deficiency. Clinical features are dyspnea, hypotension, loss of consciousness, respiratory arrest, shock. Management can be immediately stop transfusion, continuous vital monitoring, epinephrine 0.121 ml, 1:1000 dilution subcutaneously, glucocorticosteroid if severe. Immunoglobulin A deficiency individual should be given immunoglobulin A deficient plasma, was cellular blood component. Trolley is the transfusion-related acute lung injury. Present as acute respiratory distress either during or within 6 hours of transfusion. Clinical features can be respiratory compromised, non-cardiogenic pulmonary edema. On chest X-ray, bilateral interstitial filtration can be seen. Anti-HLA antibodies against recipient leukocyte. Immunization. Women of the childbearing age group who are sensitized to red blood cell antigen D, E, KEL, or DFI. Matching for D antigen is only pre-transfusion selection to prevent red blood cell elimination. Management can be leukoreduction of cellular component. Non-immunological reaction. In non-immunological reaction, fluid overload is the complication. Giving whole blood in the patient who only require red blood cells can cause a circulatory overload. Clinical features can be chest pain, cough, for the sputum. Management can be use Paxil instead of whole blood. Use diuretics before transfusion to decrease the blood volume. Transfuse blood at slow rate. Electrolyte toxicity can be hyperkalemia. Red blood cell leakage during storage. Blood that is 1 day old has plasma potassium approximately 7 milliequivalent per liter, whereas the blood stored for 21 days has contained about 23 milliequivalent per liter. Management are washed red blood cells. Hypocalcemia develops due to citrate toxicity. During massive transfusion, citrate in blood combined with ionized calcium and tetany may result. High level of citrate may cause cardiac arrest. Management is by calcium gluconate. Hemosidrosis. Each red blood cell unit contains 200 to 250 milligram iron. After 100 units of transfusion, clinical features of iron overload are common. In the management, if the iron is overloaded in the body, then erythropoietin is given as an alternative treatment. Infectious complication. Infections can be viral, hepatitis C virus, which is chronic and asymptomatic usually, hepatitis B virus, which has the increased risk of transmission as compared to hepatitis C virus, HIV-1, etc. In the bacterial infection, the relative risk of bacterial infection is more than the viral. Yersinia, Pseudomonas are the bacteria. Clinical features are fever, chill, progress to septic shock. Other infection may be which may be transfused are malaria, dengue, Chagas diseases, and the management is by a broad spectrum antibiotics. Thank you, sir.
Questions? Questions? Question आंसर होते हैं बाद में कि नहीं?
जी सर.
Yes.
सर बाद में सर थोड़ी सी सर हाँ सर थोड़ा सा डिस्कस करते हैं
मैं इसमें से कुछ पॉइंट्स हैं जो मेंशन नहीं किए या स्किप किए हैं या जैसे भी मैं डिस्कस कर सकता हूँ।
जी सर।
First of all, the blood group and antibody screen of the patient. This must be done on the first visit of the patient to the consultant. But unfortunately, the blood grouping and antibody screen, blood grouping is sometimes done on the first or second or third visit, but antibody screen is not done in this hospital, which is mandatory in most of the well-equipped hospitals in even Pakistan, like Aga Khan. In Islamabad, 1 or 2 hospitals are doing it. And this helps to prevent the blood transfusion reactions, which we miss by a routine cross-match. If we do a antibody screen, then if it comes to be a positive, then we can identify the antibody and use the antigen negative blood for that patient. But unfortunately, we are doing antibody screen like the patients we have for the renal transplant. We are doing antibody screen on the patient and on the donor, and antibody screen of some of the patients whose blood is not compatible. So we revert back to antibody screen if it comes to be positive, and then we identify the antibody, and then we go for the antigen negative blood. So most of the consultants, they advise blood group, but no antibody screening, which should be done, I think, as part of the antenatal program.
Sir, why it's not being done? Is it costly or?
Yeah, most of the consultants do say that it is an extra cost for the patient. But though the antibody screen, if we do about 500 antibody screens, maybe 2 or 3 are antibody screen positive. So the ratio is less, but still, if we are helping 3 patients out of 500, it's good enough. At least they are saved from the misery of the blood transfusion reaction.
What's the cost for anybody?
It's not much. It's 1,200 rupees per antibody screen. Regarding the protocol for placenta previa or placenta accreta increta, blood bank, in consultation with the gynecologists in this hospital, have devised the SOP for this, and you must be knowing that we are cross-matching at least 8 donors with the patient, and out of those 8, we are bleeding 4 donors, and 4 donors are on the standby, and 4 FFPs are reserved, and they are issued when they are required. Because if we thaw the FFPs, the shelf life is 6 to 8 hours. After that, you have to discard those FFPs once they are taken out of the plasma freezer, which is at -40. So you thaw it in a water bath at 37 degrees centigrade, which is a body temperature. So when they are thawed, they have to be transfused within 6 to 8 hours. You must be noting that people from blood bank are continuously, telling the post-op people that you have requested FFPs, 4 of them, they have been thawed and they are not being delivered to the post-op. For some reason, if they are not required, but they have to be discarded after 6 to 8 hours. So please make sure that order the FFPs if and when required. Otherwise, you must not order them, right? Usually the weight of the donor is 50 kgs, not 45 kgs. And if it is less than 50 kgs, then the donor is rejected. For transfusion purposes, patients' consent is necessary these days. It is a requirement from the Punjab Healthcare Commission and Punjab Blood Transfusion Authority that a patient consent must be signed before the blood is being transfused. ठीक है ना? अब मुझे नहीं पता कि आप लोग रूटीन में करते हैं या नहीं करते. Before every transfusion, do you have a patient consent signed by the patient or their relatives? Is it being done?
So, एक ही दफा हम consent ले लेते हैं जैसे अगर कोई एग्रीड
No.
not
The patient consent for blood transfusion is different from the consent which is being taken from the patient at the time of admission. You have a separate blood transfusion consent form. You can see it in the post-op area, I think so. It's not in the labor room, but patients do get transfused in labor room also, which come on the daily basis, having low hemoglobin and being transfused in the labor room and going back home. So you must have a consent form in the labor room also. हाँ, ठीक. और next is the rise of hemoglobin. Is even if you give 1 pint of whole blood or 1 pint of packed cell volume, the rise you expect is 1 grams per deciliter or 3% of hematocrit with each unit transfused, whether it is whole blood or whether it is packed cell volume. And what is the hematocrit of the packed cell volume you have prepared? That is 70 to 80%. The product which you have prepared must have a hematocrit of 70 to 80%, and that will give a rise of 3% hematocrit in the patient you are transfusing. Okay. Next come the platelet concentrates, the volume. You can vary the volume. If you are collecting a mega unit with the help of a cell separator, you can vary the volume at your own will. If a patient is an old lady having cardiac problems or there is a risk of circulatory overload, you can reduce the plasma volume from 100 mils to 350 mils. That is the range you can select for the platelet concentrates. And for platelet concentrates, as they are being stored at the room temperature from 22 to 24 degrees centigrade, and their shelf life is 5 days. So platelet concentrates are the most common cause of bacterial blood transfusion reactions because plasma is a good growth medium. So if you don't follow the aseptic techniques, though there are chances that bacteria will grow in 5 days time in that plasma, and if it is being transfused, there are good chances that patient will have a bacterial blood transfusion reaction. And what is the protocol? If a patient has a bacterial blood transfusion reaction, you have to send a sample to the microbiology lab for blood culture of the patient and the culture of the sample from the blood bag. They must tally with each other. If they are different, then there should be another source, like you have a CVP line from where you are giving the platelets, or you have a granula that may be infected from where you are giving the platelets. So the report from the patient's blood culture and the culture of the blood bag sample should tally, the same organism should be there, then it is a bacterial blood transfusion reaction. But if the source is different, then you have to look for it. You can. And for that matter, platelet concentrates and FFPs should be group specific. That is, if the patient is blood group A, you have to give platelet concentrate and the FFPs of the same group. But the RH factor is not a consideration, as most of the platelet concentrates and the FFPs do not have much RBCs in them. But RH negative women, as you have shown in the slide, if they are given more than 12 mega units of platelets or 5 pooled units of cryoprecipitate, then you have to give NTD to the childbearing women. And cryoprecipitates are usually indicated when the fibrinogen level drops below 100 milligram per deciliter. Do you have any protocol for rapid blood transfusion in your ward, or as the patient comes in to the labor room with heavy bleeding? Do you have a protocol how to proceed? Usually in the emergency situations, they have a protocol that you give 4 units of Paxils, 2 units of FFPs, and 1 mega unit of platelets to a patient who is heavily bleeding and you are using a stored blood which you have in your blood bank. Why do we use washed Paxils? And which are the solutions you can give along with blood transfusion, and which are the solutions you don't give with the blood transfusion? You can wash the Paxils with 0.9% normal saline, and you can give 0.9% normal saline along with the blood transfusion. You cannot give 5% dextrose water or Ringer's lactate. They are contraindicated. They cause hemolysis of the red cells which are being transfused along with 5% dextrose water, and you must not take a sample from those lines also. If you are giving Ringer's lactate or 5% dextrose water from the same line, that will not give the true results. The most common cause of blood transfusion reactions in patients, that is hemolytic blood transfusion reactions, is clerical error. Still today, all over the world, the most common cause for hemolytic blood transfusion reactions is clerical error. Because while taking the sample, the patient is not identified at the ward level, or the patient sample is not being labeled. You should label the sample on the bedside of the patient before shifting to another patient. And the second most common clerical error is on the blood bank staff issuing the wrong unit of blood, which must be checked by the blood bank staff and the staff in the post-op or in the labor room, the staff nurse responsible for starting the transfusion, because most of the time, if the wrong unit is being issued from the blood bank, that must be checked by the staff or the medical officer in the labor room also. But most of the time, if the wrong unit is being issued from the blood bank, the unit is being transfused as such in the post-op or in the labor room. This is missed somehow or the other. This has happened 2 or 3 times in our facility also, but most of the time it has been taken care of well in time. So by the grace of God, no fatality has occurred up till now. But still, this is the most common cause of immediate or acute blood transfusion reaction, clerical error. Any other question? The storage time of a blood bag depends upon the anticoagulant you are using. Some bags, they contain ACD, acid citrate and dextrose. Some contain CPD, citrate, phosphate and dextrose, and some contain CPDA1. The bags with ACD anticoagulants have a shelf life of 21 days. And bags with CPD anticoagulants have a shelf life of 30 days. And bags with CPDA1, they have a shelf life of 35 days. Now, additive solutions are also available in the market, and their shelf life is 40 days. So you can use that blood bag up till 40 days. The storage time of FFP unit at minus 40 degrees centigrade is 2 years. And likewise, as cryoprecipitates are also being prepared from FFPs, their storage time at minus 40 is also 2 years. Previously, it used to be 1 year, but now with the plasma freezers having a temperature of minus 40, they have extended the expiry time up till 2 years. Previously, the plasma freezers were minus 80 to minus 30. Now they are available at a temperature of minus 40. So we are using minus 40 plasma freezers, and their shelf life is 2 years. Of the cryoprecipitates, they are available in our blood bank. FFPs, they are also available in our blood bank. Any other question?
The message was में आपने किसने मैथ बताया था 4 PCBs
4 PCBs, 2 FFPs, 1 mega unit of platelets. The reason why we use PCBs is that in stored blood, some of the citrate toxicity, there's a chance of developing citrate toxicity leading to hypocalcemia and tetany, hypomagnesemia, and hyperkalemia. So that part is being omitted by using packed cells, right? Because all these are in the plasma. So if you use packed cells, 4 units of packed cells, and you, instead of the plasma of the whole blood, you are using FFPs, in which you are providing the patient with the labile and clotting factor, labile and stable clotting factors. And for thrombocytopenia, you are providing 1 mega unit of platelets. And then you reassess them. After that, the hemoglobin, the platelet count, the PT, APTT, and INR. Seeing the reports, you can rearrange your blood or blood products. By that time, if fresh blood is available, you can again shift to whole blood if the patient is losing the whole blood, or if the bleeding is controlled, then you can continue with the packed cells or FFPs if they are required. Is that clear?
Assalamu alaikum, sir.
Anything else?
Well, I have a question.
Okay.
Sir, what is meant by mega unit of platelets?